Thank you, Dr. Muhammad. Thank you for the organizing committee for the invitations. So my topic is going to be about the role of radiotherapy on the colorectal cancer. Mainly, we are thinking or talking about the oligometastatic disease. It's been defined since 1995 as an intermediate stage between the primary and the polymetastatic cancer, in which if we introduce the local therapy in this therapeutical window, then we can achieve long survival, or even we can cure the patient. The issue with oligometastasis is the definition. So there is no standard definition for oligometastasis. So many, articles or trial consider 3 metastases as oligometastasis in one organ or few organs, and some extend that to 5 metastases. So it is in between 3 to 5 metastases. It can be involve one organ or just few organs. The metastasis can be synchronous at the same time of the diagnosis of the primary, or metachronous after we cure or we deliver a radical treatment to the primary. Multiple term you will find through, around this topic. One of it is what we call the oligometastasis, which is when you have synchronous, like you have the primary and the metastasis same time. Oligo recurrence is referred to when you treat the primary and after a while then you get a recurrence of disease distant from the primary. And now there is a new term called oligoprogression, and that's being used frequently now with improvement in the systemic therapy. Here I'm just trying to illustrate some of the biology of oligometastasis, and actually it is unfair, to do this in just one slide. It is very complicated, not well understood till now, but I'm going to just mention this 2 theory to help with my topic. So we think maybe there is 2 way of oligometastasis biology. One called the linear progression model, in which that's been proven by when we test the primary and metastasis, and we found them are similar in genotype and also at the molecular level, which means that after a while the metastasis detach from the primary, and then it grows on the environment and then lead to multiple metastatic disease. So the role of local therapy here, if we stop this 2 metastases here, then we can stop the cascade of polymetastatic disease. This is one of the theory. The second theory is called the parallel progression model. And also this is proven by, in some trials, if we test the metastasis, we'll find it totally different from the primary, from the molecular stuff, also genotypically. And that's mean at the same time when we have the primary, the metastases detach at the same time, and they grow together, but at different level of or different speed. And then sometimes we'll have a polymetastatic disease from this metastasis and the other one. Again, if we apply some local therapy to this metastasis, we can prevent this cascade and then prevent the polymetastatic disease. So just some fact, as you know, 25% of the colorectal cancer will present with metastasis. 50% can develop metastasis after resections during their follow-up. Liver is the commonest, as we know. There is the colorectal cancer, actually one of the good example about oligometastatic disease and improvement in survival when we treat the metastatic sites. So we have a good literatures about 5-year survival of 25 to 40%. And actually, one of the surgical literatures reported a 10-year survival rate after liver resections for a limited liver resections for 1 to 3 Mets, and they have actually 10-year survival rate of 17%, which means this is like a cure rate up to 17% on those patients. The treatment options, as you know, it's the standard of care for most of the cases. It's surgical resections. However, that's not based on randomized trial. And the second, and the backbone for all metastatic disease will be the systemic therapy. Then we have the ablative local therapy through RFA and microwave ablation and other ablative procedure by our colleague in interventional radiology. And the new thing I'm going to speak about, which is the stereotactic radiotherapy. Stereotactic radiotherapy, it is defined as a precise focal radiotherapy delivered in a small number of fractions. That's in comparison to the regular radiotherapy where we give it over like 5 or 6 weeks. It is also described as very sophisticated treatment planning. So it needs very high qualified staff in physics and also precise quality assurance. And that lead to a very rapid dose follow-up, and I'm going to explain it later on the example. There's multiple terms used in the literature, synonyms as SAFER, SPRT, SRS, which mean the same thing. The basic principle for developing the stereotactic is radiobiology principle, in which, like we have, for example, this is the physics dose, which we measure it in gray. So if we think this is like we're giving for a lung cancer 60 gray in over 30 treatments, this is actually inside the body translated into 72 gray of effect on the tumor. But if we use the same dose, but we just put it onto 3 big treatment instead of the 30 treatment, then all of a sudden you have more than double the biological effect. This is like calculations or a mathematical, radiobiological effect, but it was the principle to develop the radiosurgery or the stereotactic radiotherapy. It is not new, actually. We use the radiosurgery in CNS cancer since 1951. Many benign and malignant condition of the CNS, we use the stereotactic. But in the body, it wasn't there because of the technology. It wasn't allowing us to use those high doses in a movable organ like a lung or liver or kidneys. But the eye-opening result was the start of using this on the lung cancer. And this is diagram, actually, this is not a drug causing these separations on the overall survival. This is simply just in 2005 and 7 when we introduced the SPRT on lung cancer, we achieved a big separation on the survival curve on those patients. So that was actually the eye-opening for us to start to use all the different SPRT technique in different organs. So the SPRT can be delivered through different machines and techniques. One of them is the Safer knife. We can use now MRI-based radiotherapy. Also, we have the regular LINAC-based radiotherapy. In our center, we have the Safer knife. It is a robotic machine. The radiotherapy comes from this robot. We have imaging system to detect the cancer during the treatment. And here we have infrared camera to detect the respiration during the treatments. The liver, we'll start with the liver. This is the common site we encountered during colorectal cancer. Here is the literature, and there is few points in the literature which is valid for the other side. First is most of our trial here is just phase 1, phase 2, or retrospective. There is no phase 3 trials. Second thing is there is no specific trial for colorectal cancer. Most of the trials include colorectal with other primaries as well. Third, which the dose here is different from study to study, and that's maybe equivalent to what the surgeon said in my hand. So this it depends on your experience. If you are experienced in radiosurgery, you will use good doses and then will reflect in good result. If you are not experienced, then you will use different doses, and that will screw the result and the literatures. The third or the fourth things here is, as you see, there is the variation local control, but there is excellent, local control over 2 years or 3 years. It can reach to the 90%. And what I quote usually is above 80% in many of the tumors we treat. And the last thing here is the side effects and the toxicity, which is minimally, so we don't have any mortality. Morbidity is very low. We don't encounter any grade 4 or 5 toxicity. Let's illustrate this on a case. So this is a 67 years old gentleman who had chemorad for his rectal cancer as the standard in 2015. Then metastasis after 1 year from the treatment. He wasn't surgical candidate because of his heart problems. At that time, he was seen by, our colleague in interventional radiology and deemed not RFA because it wasn't detected by ultrasound and they couldn't do it by CT. So the patient being treated in 2016 for this 2 lesions. First, in CyberKnife, we need to mark the lesions, and that's done through interventional radiology colleague under CT guidance. So we put this, what we call the fiducials or the markers. Those the marker, the gold markers. This is just to show you the relations or the size of them. We don't put any coils inside the patients. And then this is after the procedure. We see the coils is here. Then the patient is having MRI planning and CT also planning, and that's we use it to identify the lesions and prepare the treatment for this patient. This line is what we call the dose map. So each line means a percentage of dose around the tumor. So for this 2 lesions, the orange is the 100%, and then you see what we call the dose follow-up. So the dose follow-up, you see the white, the yellow, and here the pink one is the 50% isodose line or the 50% of the dose. So for the regular radiotherapy, other than the stereotactic, usually this pink one, we see it here. So it is not rapid follow-up, and that's not allowing us to do high dose because the other organ will be in the vicinity, so that will lead to toxicity. And when we say this is very rapid follow-up, as you see, there is maybe 5 to 6 millimeter between the 100% and the 50% isodose line. The second point I want to illustrate here, and that we do this as relax in our offices. So the patient is not in a spot, the patient is not on the table for the treatment. So I can arrange the treatment and also specify the dose and the area with a lot of time, and also not in the rush. And also the patient, when he is treated, there is no anesthesia, there is nothing, so he is just coming and goes for the treatment without any complications. This is just a sagittal view of the lesions. And here is the follow-up after more than 6 months. This is the lesion before the treatment and disappear after the treatment. The second lesion as well, this is before and this is after the treatment. Toxicity-wise, there wasn't any toxicity for that gentleman. He had just mild nausea treated with anti-nausea medications. And as for the liver function test, there was just minimal increase in ALB, which back to the normal after 6 months. This is another case just to illustrate, the wide selections of patients. So this is a huge metastasis treated with this is metastasis after resections, recurrence after resection. So it wasn't amenable for taste or tear, and then we treated this with the stereotactic radiosurgery. In this big lesion, we achieved like a stability of the disease. So the response with SBRT is sometimes different. Sometimes we achieve complete response, sometimes it's partial, and sometimes it's stability of the disease. Here, I'm just going to talk about practical thing, who is candidate for this radiosurgery or SBRT technique. So regarding the number and the size, for us is up to 5 lesions, and the size, each lesion may be up to 5 centimeters. The principle is what mentioned by the surgeon is the liver left over or the liver spare. And this is actually been adopted from the surgical literatures. If we can safely reserve 700 cc of the liver with low dose, then we can treat as many lesions as we can. So the number is just by practice up to 5 lesions. That will give us, or will lead to just barely we can cover this, reserve. But there is no limitation actually for the number or for the size. Second things we ask about is if the lesion in the capsule, because this is a problem for our colleagues sometimes in the interventional radiology. For us, there is no issues with the capsules, so it can be treated without any complications and as any other location. Third thing is being near the major blood vessels. Also for us, there is no issue at all. The blood vessels is very resistant to radiotherapy, and we never had any problems with the major blood vessels. The only thing here in the central area near the portal circulations, there is few cases reported with portal, biliary obstructions after a couple of years from the treatment, and this is less than 5%. So in the central region now, we take this in a more careful way, and then we get lower dose, or we fractionate more. Instead of single or 3 sessions, we get 5 sessions, and that's reduced this toxicity. The next is the kidneys. The kidney, we have no problem with the kidney. Actually, one of the options for the renal cell carcinoma now, which is not operable, is to be treated with radiosurgery. So the kidney usually resistant to radiotherapy, so we don't have any kidney failures or increasing creatinine because of radiation dose. The second or the other organs is the heart and the lungs. Also, we have no issues. The lung is also resistant if we can safely just get it to part of it, and with the liver, we never had any problem with the lung. For the heart, the only complication can happen is pericarditis, and that's also never been a problem because we use a dose that not toxic to the heart. The issues usually happen to us with the segment 2 when we have something close to the stomach. The stomach is very sensitive organ, and the risk is it can lead to perforations in the worst case scenario, and it can lead to ulcerations if we give it with high doses. For that, usually we reduce the dose and we give it maybe in multiple fractions. And that's what I mentioned, the beauty of radiosurgery is you do everything in retrospect. So I know what's the toxicity before I do the procedures, so I can play with the dose or with the fractionation to reduce this toxicity. The other organ also sensitive, but it is less forgiving than the stomach, is the large bowel usually, or the small bowel if it is close, especially to the segment 6. And also we use the same technique with reducing the dose or using more fractionation to reduce the toxicity. For the second commonest organ is the lung. So the lung literature is again the same thing. We have very good control and less side effects or toxicity. This table showed some literatures on the colorectal cancer itself with a small number of patients, but we achieve a very good, survival likely or survival here up to 64, comparable to the surgical literatures. This is a case, I think maybe it is the case being illustrated here by Dr. Rehan. Yes, I think. Sorry. So again, there is 2 lung lesions treated with this PRT, and the patient has no side effects, no issue in treating. The other case again, rectal cancer. No, this is I think the case from 2008. This is the case Dr. Ashwag illustrated, like treated with Dr. Ashwag and me. So this is the 2 lesions treated after multiple resections on the lung. So this is the 2 lesions. So it wasn't resectable for like this lesion because it was near the major, like the bronchi, and pneumonectomy maybe will be encountered. So this is the lesion before and after the treatment. So with that, normal, we see fibrosis after stereotactic radiotherapy. And also, this is the second lesions here treated after, and this is after the treatment with fibrosis on the area. toxicity-wise, there is no major toxicity happened with this treatment. This is a paper just comparing a match analysis between metastatectomy and SPRT in lung, and actually there was no statistical significance between the two, and actually you can see that they are overlapping, and in some areas the SPRT is better than the surgical resections on the lung. The other organ we see less frequent is the adrenals, and this is a guy we have, he has rectal cancer 2012, and then she has actually cancer 2012, then she developed 3 metastatic area at the same time in supraclav area, lymph node, para-aortic lymph node, and adrenal mets, all of them being treated with SPRT. So this is the adrenal mets. So we insert the fiducials to the area by the help of our colleague in interventional radiology. And this is the treatment, and this is the effect of the treatment. This is PET scan before and after the treatment. And this is also the CT scan before and after the treatment, the complete response of the lesion in the adrenal. Toxicity-wise, also there is no toxicity, so it is mild nausea only. There wasn't any complications after the treatment. Para-aortic lymph node, also we see a fair amount of para-aortic lymph node metastasis. So this is a guy with sigmoid cancer treated 2014. He didn't receive adjuvant chemotherapy. After follow-up, we detect an increase in CA. And then when we look for the reason, we found that he has a para-aortic lymph nodes treated with chemotherapy first. And after a few cycles of chemotherapy, we decided to go with SPRT. This is the lesion, and this is how is the dose or the dosing map of radiotherapy. And the patient was treated successfully. This is the node before, and this is the node after after treatment, so it is not affected anymore. Complication-wise, again, mild nausea and vomiting, but there wasn't any other complications. Other mets we treat as well. We have some spine mets, really like the colon or colorectal cancer go to the bone, but we have a good literature from the breast cancer and from the prostate to treat spine mets with SPRT, and it is comparable to surgical resection, brain mets as well, and peritoneal mets to less extent. Oligoprogression, this is the term I mentioned before, where because of the advances and the good result with chemotherapy nowadays, so the patients survive more, and sometimes if they have multiple sites or polymetastatic disease, sometimes you find all the lesions respond very well, except 1 or 2 lesions progress. So then I think our colleague will be in the dilemma of shifting to another, line, or continue and watch for that. So now we introduce SPRT to those progressed lesions, and then the oncologist can keep the patient on the same drug. And that's being used now more frequently on the era of lung cancer and immunotherapy. So if we have just oligoprogression disease, we treat them with SPRT, and we keep the patient on the same medications and no change. So all these advances and the usage of stereotactic lead to adopt this as an option. As you see it, this is the Canadian guideline of colorectal cancer management. And here we see the stereotactic become an option for the treatment. On the also NCCN guideline, it's mentioned here as one of the local therapy options to be offered to the patient who is not candidate for the surgery. And that's also reflected in our practice as radiation oncologists. So the usage of SPRT increased dramatically from 2005 to 2010, and many centers now use it as a standard for oligometastatic disease. So the futures, again, will be in the randomized trial, because we don't have any randomized control trial to compare different technique or to compare to do the SPRT or not. And there is many on the way. Some of them is exclusive for lung or breast, and some of them include multiple primaries on their inclusion criteria. As summary, I think In the oligometastatic disease, we still lack randomized controlled trial to specify those patients will benefit from the local therapy. So the basic principle to me is do no harm. So if the treatment will cause harm and we don't know exactly if it's going to improve the survival, then we shouldn't do it. The SBRT is very cost effective. So the risk of complications is very low, and we have less than 5% grade 4 or 5 toxicity for the all organ we treat. And one of the advantages, we can treat multiple sites at the same time. We can treat the lung, liver, adrenal on the same session without any interruptions of the chemotherapy. And the acute complications is very low. So if we sandwich the treatment in between chemotherapy, then we don't have to break the chemotherapy to get the SBRT. So we can give it in between. And we have done this with some cases. As I mentioned, it can be a good alternative to a difficult located metastasis on the liver or in the lung. If it can lead to a major surgery, then the SBRT will be a good alternative. And by that, I conclude. Thank you.